Without much further ado, I want to introduce our keynote address for today. We all know Dr. Mercy Mwangangi, CBS. She's a medic by profession, holder of a master's degree in health and economics and policy from University of Adelaide, Administrative Secretary, Ministry of Health in Kenya. She also serves as a joint secretary in the task force of universal health coverage. She's a member of the African Women in Leadership Network. And of course, in matters COVID, it's generally agreed that her presence on TV is a breath of fresh air. Dr. Mercy Mwangangi, welcome to give your keynote address. Thank you.
Thank you so much, Dr. Miano, for that kind introduction. And let me begin by thanking our members for PSK for extending this invitation to the Ministry of Health. We are quite excited to always meet with you and collaborate with you and engage with you. And we really do value your contributions in terms of one, moving this health system forward, in terms of meeting the UHC objective and continued, of course, service delivery for our citizens. Let me begin a little bit off the mark by saying that I am looking at the chat box right now, and I can see some of us are planning to be vaccinated. Faith says she's planning to be vaccinated. I can see somebody saying that they feel the queues in Bagadiwe are too long and it discouraged them. And I think I've seen one more comment from Nito, who says she got vaccinated in Kisumu and someone else got vaccinated in Nanyuki. I think it would be remiss for me to just jump into supply chain issues in terms of my address without, of course, discussing with you all when it comes to the COVID-19 vaccination deployment that is currently underway. And just to perhaps highlight and to share with you that so far the exercise is underway. We do have about 622 centers that are accredited for this vaccination drive. And so Doreen and other people who are discouraged, Daniela, in terms of trying to go seek services in Bagadiwe, you still have other options available to you, particularly if you're in Nairobi. I will be attaching to this chat box the list of facilities that are accredited in Nairobi beyond Kenyatta and Bagadi. We also have facilities like Riruta, and many others that actually have very, how do I say, fewer lines and less lines and less waiting times. And so we'll avail this information for you. And of course, also encourage yourselves as frontliners to really come forward, one, for the vaccination to protect yourself, but two, to also partner with us when it comes to sensitizing the communities. I think nobody is best suited perhaps to even discuss this than a pharmacist, because essentially you're the ones who know how these molecules work. You're the ones who are the technical experts in this area. And so really we want to hear a stronger voice from PSK. And now I'm calling on to your chairmanship and your secretariat and your leadership. We want to hear a stronger voice from yourselves. And we're happy to discuss with you, even if it's informally or in boardrooms, any concerns that you may have with this vaccination drive. However, really it's to plea that you really partner with us and be louder in terms of advocating for Kenyans to receive this vaccine and for us healthcare workers to receive this vaccine. And I do like having very interactive sessions. So if you have any questions for me, if you have any concerns, if you have any messages that you want to send to government concerning this, please vaccine deployment. Jumping into our discussion for today, I was asked to make remarks and to make remarks that touch on, sorry, I'm being told my internet is unstable. I was being told to make remarks today and make remarks that touch on the health system requirements of the pharma supply chain. And this really is an important, discussion and topic, particularly now, as we've been trying to deal with the COVID-19 pandemic. I can share with you lots and lots of examples, particularly last year when we had resources at hand. We actually had budgets availed by Exchequer, but were actually unable to get some of the products that we needed, particularly when it came to testing, when it came to sample collection, PCR testing for COVID-19, but also when it came to the supply of some, life-saving medication, particularly for malaria. I'm sure you all remember there's a time we had acute shortages for AL, and later on even for HIV commodities. And so really, he brought in the question of, okay, you can have the resource available, you can have the money available, and the supply chain mechanism or system can actually fail you, and you can actually end up having stockouts. And so really, it one, of course, taught us as a country, as a government, the issue of self-reliance. And I think you've had us speak about this over and over again. We've talked about, one, promoting local manufacturing. And I know this is a discussion that PSK has had with us. Perhaps I do remember 3 years ago engaging in the same discussion with yourselves. However, I can say perhaps one of the silver linings of COVID is that this has been sort of brought to the fore and is now being looked at much more seriously, much more intentfully, much more deliberately. And just to share some details of how we are doing this is that we do have a gazetted list of medicines and commodities that we intend to restrict their procurement to local manufacturers. And this is, through directives from His Excellency's office to ensure that we actually promote this local manufacturing within the country. But then going beyond that and going beyond the prized lesson of self-reliance and being able to depend on yourself, when we look at the health system and perhaps then mirror that with supply chain management, I was thinking about this and I thought, okay, so what is the one ask that we have when it comes to supply chain? At the end of the day, no matter how sophisticated the framework is, no matter how sophisticated the pathway is, no matter how many principles we learn when it comes to supply chain and the things that we should pay attention to, at the end of the day, what we care about as a client, as an individual citizen, as government, as a health provider, is that I get my medicines, products, commodities on time. And I think that's, something that we need to reflect on, that, even as we sit and conference for 2 days, everything that we are discussing, all the new interventions, all the new technology, all the sophisticated, sexy IT mechanisms that are available out there right now, the end point of it all is that, one, we ensure that this product eventually gets to me on time and particularly responsive to my needs. And if this is the way we're going to look at this, then of course, meeting this goal requires us to reflect on our current ecosystem, our current sort of organization of the system and how it works. And one of the key things we've noted is that in the medical industry, right now, if you look at the price of even basic medicines, basic commodities, even just looking at the past 2-3 years, we've seen a steady increase in price of these commodities. And right now, the discussion, particularly when it comes to UHC, we've been talking about making care more affordable. We've been talking about easing access to these health services and products to Mwangangi. And one of the things that has been determined, particularly when we look at some matrices such as out-of-pocket expenditure, is that the key cost when it comes to price escalation is actually the supply chain and of course the cost of medicines and products and technologies. And so it becomes important, one, to recognize, one, as a society, PSK, and as members in this space, we are duty bound to be able to look at these increasing escalating costs and ask ourselves, one, how do we remove or reduce inefficiencies that can perhaps, if not drive down cost, but at least stabilize cost? And number two, how do we then improve on these turnaround times? And the thing is, particularly within the Ministry of Health, we've grappled with this over and over again. What is the magic button when it comes to removing these inefficiencies and driving down costs? What can we do? And in this regard, we've had different interventions I'll be sharing with you, different discussions at the leadership level, at the technical level, in terms of what can we do to get this product to Mwangangi, to get this product to Nanyuki Hospital, but to ensure that we're actually removing inefficiencies, albeit perhaps reducing them, and most importantly, perhaps having predictability in price and reducing the volatility when it comes to that area. And when we look at the different components of how Kenya manages, its supply chain framework, I think one of the most resounding things is that sometimes there's a glaring misalignment in terms of the different activities if you look at the supply chain pathway. And I'll share with you an experience. About 2 years ago, we rolled out a UHC pilot exercise. I'm sure most of you are familiar with that. And the exercise actually took an approach of looking at input financing and therefore the provision of different inputs. So these are the medicines and the commodities, both pharma and non-pharmaceuticals, through KEMSA. And one of the should I say, pros of the exercise, and one of the things that we received as feedback from the counties, the 4 counties who participated, is that they were especially happy to have received the commodities, and they felt that this was sort of a gap that they had. And clearly this pointed to us that there was an unmet need. But in the same frame, and much like a double-edged sword, one, there was disinvestment by the county infrastructure when it came to availing more resources for commodities. But 2, also, very, very glaring misalignments when it came to the orders, in terms of the drawing rights that the different counties were pulling on. And I remember, grappling with issues of, okay, so if this is a problem that's presenting itself in the first quarter of this pilot exercise, can we embark on quantification exercises in all the 4 counties and sort of create new agility in the system so that if Machakos is ordering XYZ commodities, that they're doing that on a background of information on consumption and patterns, disease patterns, and something that can really help them perhaps, make best use of the limited drawing rights that they had. And I can tell you during one of the review and assessment exercises we had the governor of Laikipia, actually make a very diplomatic remark and say that for him, his concern is that in Laikipia, he needed drugs for patients who have arthritis. And yet, out of all the drawing rights that we had given him and all the medicines that he was able to access, he could not access arthritic medication. And sort of, that became really, how do I say, a glaring lesson for us that at the end of the day, even when you have, again, the resources available, even when you have intent and political commitment, it seems that our supply chain framework is very misaligned and perhaps works in a very siloed approach. And so today, as we address the issue of, what are the emerging health system requirements when it comes to supply chain, and one of the key things, and perhaps for me, if there's anything that anyone should take from my speech today, is that you all have to come to the table and figure out how you truly integrate the different components that come about in terms of the supply chain system. And I'm glad because I looked at what you discussed yesterday and I've looked at your program. I can see bits and pieces in terms of the program, in terms of how these systems come together. And I'm hoping that one of the outcomes of this conference will be perhaps beyond conversation, some form of blueprint on what then this true integration looks like. And I know we've discussed perhaps the technical details of how do we look at our inventory systems, how do we look at our suppliers, can we aggregate our suppliers, how do we look at vendor management systems, do our ERPs serve our needs, can we look at some of the sexy new technology like RFID technology? And there's an interesting story here. Before 2019, we had the opportunity of engaging with the Dubai Healthcare City team members, and in particular, one of the subsidiaries, Cleveland Health, who we all know about. We know about Cleveland Clinic, and they took us through the neonatal units, and they were actually using RFID technology, and we were very excited. We need to do this here in Kenya. We need to come down and we need to use this. This is a game changer. And again, I can tell you, sort of jumping into the same hole of siloed approaches. When we try to come back and look at how that can look like here, and I'm aware it still hasn't taken off, it sort of became important for us to ask ourselves, even if you put this technology in place, how does it align to the other different components of the pathway? And so really, as we look at the health system, it's important to take note of, issues of information technology systems, issues in terms of demand, issues when it comes to forecasting, issues when it comes to even the human resources who are available to provide these services. And again, here, another interesting experience. When we were looking at the pilot exercise, we came to learn that some of the aggregation of the needs actually happens at the county department level of health. And when we went to the sub-county levels, when we went to the health centers and the dispensaries, talking to the health facility managers, they actually told us that they lack the autonomy to be able to actually make an order. And that every time they make an order, despite themselves being the ones who are on the ground, the order still has to be aggregated through the bureaucratic system that we've created, and sort of managed at a central level. And that was interesting to hear, because it wasn't just one sort of experience in Machakos. This came out of Kisumu, Laikipia. And so then again, if we're looking at a health system, then key things we need to discuss about when it comes to improving our supply chains are issues that touch on provider autonomy, particularly in the public sector. How do we actually allow that autonomy and ensure that that autonomy can actually be dependent on, even as we talk about, economies of scale and wanting to align issues centrally and wanting to perhaps moderate orders. How do we have that fine balance between providing autonomy to perhaps our sub-units, while still, of course, having a facilitative role at the central level? Another key element that I should talk about again is then on price regulation. I'm sure again, we've had discussions with yourselves, and this, we've had different directives on, can you come up with a plan in terms of how you can ensure that there's a component of price regulation in the system, and price regulation that perhaps again has a fine balance. And one of the key things that we are doing right now, in fact, as we speak today, there is a team of officers who are in Naivasha who are undergoing capacity building when it comes to health technology assessment. And Kenya has been able to develop a health technology assessment framework. And it's just one of the many tools that we can utilize when it comes to trying to ensure that some of our products and medicines are available. And so then my question to you as society is, how do we then take a tool such as HTA and start perhaps being, should I say, the stewards of this tool, particularly because you're the ones who are in the industry, to ensure that this tool then meets the merits that it provides for us in terms of being able to have a more rational way of decision making when it comes to the price of our medicines and commodities. Of course, data. I've seen discussions. Data is very important. Most recently, as you're aware, in KEMSA, there have been reforms, particularly in looking at the procurement system, in looking at that interconnectivity of that procurement system with IFMIS. And as we've been engaging with the board and the technical teams in KEMSA, we've pushed further and really required them to demonstrate that granularity when it comes to some of the orders that they get, relating them to the consumption in the counties, but also perhaps in future, looking at how our predictability when it comes to forecasting and quantification can be informed by sophisticated AI models. And I'm aware that different teams that are piloting this, to try and look and see how can this actually provide more information that informs decisions better. I think also part of the health system, and particularly when it comes to supply chain, it's just as well to get the product there. And yes, that is the goal of the system, of the supply chain system. However, there's need perhaps to then think about the feedback mechanism from the consumer, the feedback mechanism from the provider and the end client, and particularly when it comes to pharmacovigilance. I think this is an area we definitely need to strengthen. I think it's an area that will actually support supply chain mechanisms to be more agile and to be more responsive, and perhaps even reduce costs if we can have that aggregate data when it comes to pharmacovigilance, and ensuring that the commodities that are being utilized by Mwananchi, by providers, there's a mechanism to feed back and to then inform, of course, our manufacturers as they move this forward. Of course, the health financing system also becomes important. The interrelation and the play between government, the regulator, industry players, and perhaps the newcomer in this, the insurance companies, both the public sector one, here I refer to NHIF, but also the private medical insurance industry players, I think also is an aspect that we need to look at. And it's an aspect where our health system needs to be a bit more ready and a bit more responsive, and I dare say a bit more innovative. I'm aware there are discussions underway in both places, both public and private, to have insurance companies perhaps play a more deliberate role when it comes to looking at the cost of commodities, but also when it comes to looking at the quality of the commodities that we have in place. And so I think there's no time like now for the industry to start engaging in these discussions, to start looking at some of the bundled payment systems that we are exploring, to be able to see how do we actually then improve the supply chain at the end of the day and improve this turnaround time of getting a commodity by looking at the insurance mechanisms that we have in play. And these are discussions that we're happy to convene for you and to broker for you, because these are discussions that are, advancing very quickly to see how, again, the health financing architecture can be a bit more responsive to citizen needs, and then of course to ensuring that the supply chain is more robust in terms of its objective of delivering the commodity. I could go on and on and on. This is an area I particularly enjoy, and that's why I'm quite excited that PSK asked me to come in. I can already see lots and lots of questions, so I want to sit back and start answering those questions in the chat. However, we do remain available to you. We do wish you success in your deliberations, and of course, continue encouraging continued collaboration with us as we aim to deliver UHC to Kenyans. So thank you so much. I think I'll hand over back to our moderator, Dr. Miano. I can't see him, but he must be there somewhere. Terry, over to you.
Dr. Mwangangi, thank you so much for the very good remarks on supply chain efficiencies. So yeah, I'm here actually. I'm in the background. So I guess the Q&A. So Dr. Mercy, you are dealing with very intelligent people in this meeting. So you have to answer this one here from Dr. Chris Masila. He is asking, what's the future of molecular diagnostics now that PCR is becoming a game changer due to COVID, but was minimally used in our labs? Then he also asked, is there any RDTs approved for? Of course, he talks about testing and tracing. And then finally, what are the learnings on ProKick? So please answer the question in the best way you can.
Thank you, Dr. And that's why it's especially stimulating to be here and to engage with you. I'm not sure if I'm getting an echo if someone has their mic on, but I'll continue. One, I think I'll start with molecular diagnostics. Yes, indeed. I think for Kenya and perhaps the world over, the role of this has now been more pronounced. I can tell you as we speak right now, we have about 47 centers that are doing PCR testing across the country. And one of the things that we're looking to do, particularly in collaboration and under the One Health framework, which you may all have heard of, is look at this space of diagnostics and provide more investments for it. In the near future, you will be seeing a reformed KEMRI. We are in the process. I think you've already seen we now have a new chair in KEMRI, and there'll be a few reform structures undergoing within them. One, to accommodate what we've learned, should I say, the resourcefulness of molecular diagnostics, and also the adaptability of those. And I'll share with you a funny finding. So last year, we did a lot of investments in setting up PCR infrastructure across the country, of course, primarily geared towards COVID-19. And the paradox of this is that last year, in the very same year where we're investing in this infrastructure, we actually had a problem when it came to early infant diagnosis for HIV. Yet this is a test that more or less uses the same technologies and apparatus and infrastructure. And I remember during the meeting where it came to, our attention that EID diagnosis had perhaps even taken almost a 20% decline hit. Waziri asked, so then how do we then, beyond just running and focusing on COVID, how do we look at that whole infrastructure when it comes to molecular diagnostics and come up with a business plan for it? And again, it's easy for me to say this, but as industry, this is the feedback that we want, and perhaps also the proactiveness from your end to come to us and say, so this is the blueprint of a business plan of investing in this space, and this is how it's going to look like. Right now, as we speak, we have only 3 centers, I think, that are doing genomic sequencing surveillance for the new COVID-19 variants. We have Kemri Kilifi, we have Kisumu, but also ILRI is supporting us. And again, the discussion comes in, how does Kenya, beyond looking at just the health sector, look at the infrastructure across it and ask ourselves, what do we need to do to improve upon it? So what I can say is that right now, in terms of where we are, is that this has been recognized as a need. There are discussions, particularly through Kemri, to develop a business plan and investment case for it. And we welcome you to really join these teams and contribute. And one of the good things that I know that is happening, particularly when it comes to human resources for health, because the 2 and 2 go in hand, is that for the first time ever, we shall now recognize what you'd call, biological scientists beyond the normative doctor, pharmacist, lab technician, the normal cadres that we have in the health system. For the first time, we're recognizing biomedical scientists. We are recognizing that whole cadre, and who has the teams who really do a large component of diagnostics. The lab scientists who are advanced in terms of their expertise and their training will all be recognized. And we are working again with Kemri for them to give us who are all these cadres who've often been forgotten, and skill sets that have often been forgotten and are not mainstream in government, and how do we onboard them, get them recognized by the Public Service Commission, and develop schemes of service for them, and ensure that then they're onboarded in the system. So these are some of the little components that we are doing to address this. In terms of learnings, in terms of procurement, I think for the first time ever, it's become very clear that we have to, even when we have KEMSA and, it's a bulk procuring agency, it may be that within KEMSA, one, we need to look at the act or the bill and put in place some reform structures. We've had issues when it comes to procurement and perhaps even access to manufacturers when it comes to procurement. And right now there are frameworks in place to actually enable direct procurement from manufacturer. We're looking at also, contract manufacturing of some of those commodities to ease, their availability within the country. We are looking at the systems that KEMSA utilizes. We're also looking at perhaps, our procurement laws and particularly emergency procurement laws. How do you ensure accountability, but also agility when you're trying to avail a commodity? And these are some of the little things that are underway. I think very soon, last week, we engaged with the KEMSA team, and they should be coming to you to share with you some of the deliberations that we have in that space. There is also active engagement right now to actually perhaps broaden the SSD component of KEMSA and allow private sector to actively engage and procure commodities from KEMSA. Last year, we had lots and lots of discussions with the private sector, and some of them said, we are happy for you to actually, use our resources, get our resources, and expand and get these reagents in for us. But the framework of doing that was not available then, and this is something that then we've been directed to ensure it's available, so that we can have private sector engagement in this space. I don't know if I've answered all the questions. Miano, if there's one.
So I can help you so that we are able to be a bit efficient. So there's a question about lactating mothers. Should they be vaccinated? So you can answer this together with the one that they've asked about someone who's tested positive. What's the protocol? Should they go for the vaccine or they should wait? And finally, they are asking about access to the elderly, the vulnerable, like what is the ministry doing to access especially people in dialysis centers and those kind of the vulnerable groups. So you can answer those 3
Okay, great. So on breastfeeding mothers, and I'll couple this with pregnant mothers. So far, in terms of the trials that are underway, none of those trials were undertaken in that cohort, in that demographic of pregnant mothers or lactating mothers. However, our engagements, with the manufacturers, AstraZeneca, Pfizer, Moderna, all say that, they've not, particularly in animal studies, they've not seen any transmission or any ill effects in terms of a lactating mother using the vaccine. What we are advising the community, because again, remember all this has happened under a background of emergency and acceleration and trying to move this process really forward to avail the vaccines, is that The mother needs to just make a choice for herself. And of course, in comes the question of indemnity. Right now, for the COVAX vaccines that we have coming in, there is an indemnity agreement that will be facilitated by WHO and COVAX. For those who are bringing in the vaccines through the private sector, the indemnity will be guaranteed by those bringing in the vaccines and not government. And so those are the mechanisms that we have in play. Now, if I, Dr. Mwangangi, was pregnant or was breastfeeding, would I take the vaccine? And I think I'd make that decision based on what I perceive to be my risks. If I'm a healthcare worker, which I am, and I'm working in a health facility, and therefore then I'm at high risk, then I think I would take the vaccine. And that perhaps is a very subjective decision. So right now what we're saying is that you have to make an informed choice, and that is why this is voluntary. However, in terms of data, we don't have any information, particularly because no trials were undertaken in that demographic. In terms of, I think the other question, Miano, remind me, what was the other question?
So I think you've answered the ones on the vaccine and access. So there's another one they're asking. Yeah.
Continue.
So they're asking about confusion about what is authorized in Kenya and specifically Sputnik. What's the government position on Sputnik vaccine?
Okay, so the two last questions on access and dialysis, I think that was the other one. In terms of access, so when we started, we came out with a deployment plan, and our plan was heavily guided by what the WHO SAGE group, there's a group known as SAGE who were developing priority lists and advising countries to adopt those priority lists. And the priority list was as follows. You start with your healthcare workers, your frontliners, and then you get into phase 2, where you do those who are over 50, who have comorbid conditions. And then you get into those who are in aggregate populations, such as refugee camps and whatnot. That was the plan that we had at hand. And I can tell you, having a plan on paper and execution, are two things that are different, and you really always require to be very pragmatic and agile as you execute your plan. Right now, we have a little under, we have about 1 million doses available in the country for AstraZeneca. And in terms of demand, each day that passes, our demand is increasing. We're seeing an appetite for receiving the vaccines. When we started, we were doing close to just maybe 1,000 cases a day. Yesterday, we were well over 11,000 just for yesterday. We are seeing and hoping in the coming few weeks, we'll get to 20,000 a day. What is most likely to happen is that, and this is yet to be formally perhaps communicated and decided upon, but it may be that as opposed to keeping reserved doses, so that then if you got your dose, at the beginning of the vaccination drive, you come in for your second dose, 8 weeks later, we're thinking and trying to see, is a strategy that we roll out the 1 million doses to the community, and then perhaps then ensure that we have the second doses available so that people still get their second dose on appointment and on the appointment dates that they were given. These are discussions that are underway. And why I'm sharing this with you and why this is important is because the vaccine actually expires in June 28th, and for the other 100 doses in July 28th. So we have almost like a deadline, we have a time frame of when we have to ensure we've consumed those vaccines. And so we will be considering this as government, and particularly the task force team will be considering, do we then look at mechanisms to start onboarding those who have chronic conditions and those who are over 50. And it may be that if you're going to a dialysis clinic, the vaccine will be available for you there. If you're going to MOPC, diabetic clinics, all these clinics where we monitor the chronic conditions, particularly MOPC and GOPC, again, the vaccine will be availed at those centers for you to take it. It may be even that because of logistic issues, we may give a blanket declaration of those over 58 with or without comorbid condition to present themselves for vaccination. So that's sort of how we are looking at it. When it comes to Sputnik 5, the approach that the Kenyan government has taken is that we're encouraging private sector engagement in this vaccination plan. That we recognize as government, we may not be able to reach all the people who need to be reached with the vaccine, particularly in the timeframes that we have, and also looking at the resource constraints that are available. So the idea, of course, at the end of it is to vaccinate as many people as fast as possible. If we could, ideally within a week, everyone would be vaccinated, and then perhaps we'd be able to come to a new normal. And so what we've done in recognition of this situation is that we have encouraged private sector to come in and partner with us in deployment of this vaccine. So Sputnik is approved by PPB and is available within the country. Shortly, the distributor will be providing this vaccine to different facilities. I know you saw in the media yesterday, the day before, different facilities advertising for it. That is actually prohibited. So we will be coming after those facilities because there's a mechanism through which we have to regulate the availability of these vaccines in the Kenyan market. Beyond Sputnik, we actually have 3 other candidates right now who are under review at PPB to see if and when they qualify, if this vaccine will be available, to Kenyans for them to purchase and, be able to get the vaccine. As this goes on, even as government right now, even as we have AstraZeneca, we are in discussions with other manufacturers to bring in their commodities. So at the end of it, you will actually see different vaccines available in the Kenyan market. I think I'll end it at that and hand over back to the host.
Thank you, Dr. Mwangangi. We really appreciate the responses. Kindly, if you have some time after I let you off, please go into the Q&A and type answers to some of the questions that are still running. And thank you for telling us that it's not Sputnik V like we are hearing on TV. It's actually Sputnik 5. Yeah. So I want to give an opportunity to our PSK CEO, Dr. Daniela, to give some remarks.
Okay, Dr. Mwangangi, mine is just to thank you for taking time off your busy schedule to attend our Pharma Supply Chain Conference, and to let you know that we've noted all the challenges that you've posed to us as pharmacists, challenges around cost containment, efficiency of the supply chain, pharmacovigilance. Those are really our areas of specialization, and we have taken that to note. Asante sana, and as Robert said, if you have some time before you log off, you could just answer a few more questions because there are so many questions for you. Thank you.